Welcome to our series of videos that will help you to apply a systematic approach to focused patient assessment. We appreciate that you want to enhance or refresh your skills and need support materials to enable you to do so. We've therefore produced this series of videos to demonstrate the skills of focused physical assessment appropriate to out-of-hospital care, and have sought to do so in a way that you can access anytime and anywhere to suit you, and through media such as smartphones and tablets. The scripts clearly show the clinical procedures and form part of a right care educational package. These videos are based on Best Available Evidence 2014 and complement your normal protocols and practice. It's therefore assumed that in every instance, assurance of verbal consent and mental capacity has been confirmed, and a thorough primary survey or initial assessment has taken place to determine whether the patient is time critical or not, and whether any immediate interventions are required. It's also assumed that this objective data in the form of baseline observations is combined with comprehensive history taking to determine further assessment and diagnostic tests. History taking is not the focus of these videos, and neither are the primary survey and baseline observations. Therefore, these will not be referred to. Essentially, physical assessment forms part of the overall picture, and when combined with accurate and appropriate initial assessment, history taking and diagnostic tests, should help you to ensure that you make an appropriate clinical decision when determining ongoing care. The first part of the physical assessment process starts with your initial and general impressions. Often this can help lead to a specific diagnosis or indicate the focused assessment that should take place. The physical assessment starts as soon as you meet the patient. In addition to carrying out the primary survey, you should note a patient's general demeanour and physical appearance, noting how they rise from the chair and walk into the room. This is an opportunity to assess the general appearance of the patient in relation to health status, weight, stature, posture, colour, hygiene, odours, dress. As you greet your patient in a friendly, professional manner, you can gain information around underlying conditions such as rheumatoid arthritis. You should then continue to a more detailed assessment of the arms and hands, noting any abnormalities in the skin, nails, soft tissues, tendons and joints, such as finger clubbing and Dupuytren's contracture, splinter hemorrhage, cyanosis, ulnar deviation and skin turgor. Assess the patient's facial expression and general demeanour, asking yourself, does this patient look well? And what's their nutritional status? Are they obese, wasted, muscular? And consider fat distribution and edema. You should observe mood and behaviour and report accurately. Cooperative, happy, sad, resentful, depressed. Factors such as anxiety, fear, anger or grief are all expressed through facial expression and can have a significant bearing on both mental and physical health. You may get clues suggesting underlying dementia or mental illness from the state of clothes that people are wearing. You can assess the colour, texture, temperature and hair distribution of the skin in general. Also consider sweating, dryness, any lesion, elasticity, turgor, and explain the possible significance of findings. When taking note of the facial complexion, abnormalities such as cyanosis and jaundice can vary according to oxyhemoglobin and bilirubin levels. You can also note the appearance of eyes and comment upon the possible significance to health of exophthalmos, squint, redness, conjunctiva for anemia, sclera for jaundice, and arcus senilis, for example. Odours can also indicate smoking history, alcohol intake, and specific pathology such as the sweet smell associated with ketoacidosis. The next step is to take a baseline of all vital signs, including blood pressure and temperature.